All right, Doc, just a little bit of a sound check. Just say hello.
Hello, hello, hello.
It sounds good. Volume's good. I'm going to turn you on now.
Okay.
All right, so the world can see you.
I'll be checking it now.
Ready to go?
Yeah, 358. So no, I'm just going to
All right.
I don't want to be distracted.
We'll wait till 3:15. I just want to make sure that it gets recorded by your coders.
215, Tom? 215.
The picture looks great.
771.
In fact, let me do a zoom in quick, just to make sure I get a deep depth of focus.
In case I'm like sitting at my desk and desperate.
Thank you.
All right, sure.
Good afternoon. I'm Dr. Zachary Post. I'm a joint replacement surgeon from the Rothman Institute. I specialize in hip and knee replacement, and we're here this afternoon to answer your questions and talk about hip and knee replacement, and specifically knee replacement and what things are new in knee replacement. I think we've already got some questions lined up, so why don't we go ahead and take the first question. It's from Potluck65. How do you determine if someone needs their hip or knee replaced? Well, thank you for the question. That's a great question, and it's one that's hard to answer without an x-ray. And an x-ray, as it turns out, is the thing that will help. Hip pain, and especially knee pain, is usually worse with walking, activity. You know when your hip and your knee hurts. Knee pain specifically has trouble with going up and down the stairs. It'll give you pain. It'll give you pain when you walk for long distances. But one of the pathognomonic, or I should say the classic indicators of knee arthritis is pain at night. If you're having pain at night, that's a strong indicator that something's not right in your knee. An x-ray done in your doctor's office will help determine what's going on. There's lots of possibilities. Arthritis is just one of those. But based on your x-rays and an examination, the doctor can get to the bottom of what's causing the pain, and more importantly, what you would do next to make it better. All right, let's go to our next question. This is from Samantha E. Does arthritis eventually lead to the need for a knee replacement? Can years of dancing make it worse? Samantha, thanks for the question. That's a great question. Arthritis can lead to a knee replacement, but arthritis varies in how severe it is. Some people have mild arthritis that they live with for years that never requires knee replacement. Other people can have no pain and within a few months develop severe arthritis that ultimately leads to knee replacement. Activity has not been strongly associated with knee replacement. The one study that comes to mind, a few years ago, somebody did a study on runners, and if runners had a higher incidence of knee replacement, which makes sense. If you're active, if you're running, you're going to use your knees more and you'll need a knee replacement, or you'll be more likely to need a knee replacement. But as it turns out, that wasn't true, that runners had the same incidence of knee replacement as people who didn't run. So if you enjoy dancing and your knees don't hurt, by all means, keep dancing. If you enjoy running and your knees don't hurt, keep running, because the likelihood you'll develop arthritis and need a knee replacement is no greater than people who don't run or dance or do anything that they like to do. All right, let's see. Next question. How long will I be in the hospital for this procedure? This is from Jeff. Jeff, thanks for your question. This is something that's changed, and we're talking about the improvements in knee replacement. This is one that's changed dramatically in the last few years. It wasn't that long ago that patients after knee replacement would stay in the hospital for 5 days. We didn't even get them out of bed until day 2. Nowadays, we get you up immediately. In fact, if your knee replacement is on Thursday morning, by Thursday afternoon, you will be up and walking on your new knee. And most people, about 70% of people, will go home the next day. So there's really not much time in the hospital, and that's because of advances in technique and advances in the medicines we use. I think even in spite of people going home early, I think that people are having less pain. They're getting up faster and they're moving sooner with less pain. So if you're planning on knee replacement, don't plan on spending a lot of time in the hospital. In fact, plan on being up, walking, and doing therapy as much as, or maybe more than you're doing even before you have your knee replaced. Good question, Jeff. Next question. What is osteoarthritis and rheumatoid arthritis? This is from David. Well, David, another good question. Osteoarthritis basically means wear and tear. So, somebody who uses their knees a lot, walking or working or doing things like that, that's osteoarthritis, when the knee basically just wears out. Rheumatoid arthritis is something different. Rheumatoid arthritis is an inflammatory condition. It's a disease. It affects many joints throughout the whole body. Osteoarthritis is more likely to affect knees or hips or both or maybe just one. It's not specific, but rheumatoid arthritis is going to affect all the joints in the body. Rheumatoid arthritis frequently results in massive arthritis of the hands. There have been some improvements in the treatment for rheumatoid arthritis, but thankfully it's a rare disease. Most people who have arthritis and are going to deal with knee pain have just basic osteoarthritis and not rheumatoid arthritis. All right, let's go to our next question. This is from Eli. Is 83 too old for the surgery? Well, Eli, 83 is relative, as I'm sure you know. I assume you might be 83. Let me tell you about one of my favorite patients. She was 94. It's a lady I go to church with, and I saw her hobbling around church for a long time. And she finally came to me and said, "My knee is killing me. Can I come see you in the office?" And she did. And when I came through the door, the very first thing she said was, "You're not operating on me." I said, "Okay, all right, calm down. Nobody's planning any surgeries." And we did everything to try and help her knee feel better. We did injections. She had physical therapy. She tried some medication. Nothing helped. Eventually, we did end up replacing her knee, and she did great. So that's the long answer, but the short answer, Eli, is that health is relative, and it's not the number that we're worried about. It's more of the health status. If you're 83 or 93 for that matter, if you're healthy enough for surgery, the knee replacement might be a good operation for you. All right, let's go to our next question. What are some of the recent improvements in the procedure? Comment from Michael Kessler. Well, I mentioned earlier the rapid recovery, that the recovery is much faster than it used to be. Another important improvement, I think, is the use of a medication called TXA, which is tranexamic acid. One of the risks of knee replacement used to be the need for a blood transfusion. As with any surgery, when you have your knee replaced, there is some blood loss. That sometimes resulted in transfusion. In fact, we used to have everybody donate 2 units of their own blood prior to surgery so that we could avoid needing to transfuse somebody else's blood. But in the last few years, we've developed this medication that, given at the time of anesthesia, it prevents bleeding. In fact, we've seen the incidence or the need to have people get transfusion go from about 15% down to much less than 2 or 3%. So the risk is very low of needing a blood transfusion, and that's all due to this tranexamic acid, which has been a significant improvement. It's one of the things also that's helped us allow patients to go home earlier. Less bleeding in the knee means less swelling, less pain, faster recovery. All those things contribute to an improvement. So tranexamic acid is a significant improvement that I think we've seen just in the last few years. Great question, Michael. Thank you. Let's go to another question. Do we have one more? Oh, I might need to scroll. All right, this is from Barb. What are the weight restrictions for bilateral total knee replacement? I'm 54 years old, obese, and have been most of my life. I am bone on bone and was told 5 years ago that I need them replaced. Well, you bring up a couple of very interesting questions, Barb. First is bilateral knee replacement. For those of you who don't know, bilateral knee replacement means both knees at the same time. It's not so much a weight restriction for bilateral knee replacement as it is a health restriction. And in general, we try to restrict patients who need bilateral knee replacement to people who are healthy. So you've got to be, in general, very healthy to get them both done at the same time. If you have a history of diabetes or heart disease, if you have sleep apnea, these are just a few of the health problems that could prevent you from getting them both done at the same time. The vast majority of people get their knees done one at a time. And if you'd like to, you can get them done relatively close to one another. But to do them both at the same time, you've got to be healthy. Your second question brings up an interesting issue, which is weight and being overweight. In general, we feel that patients who have a BMI, which is body mass index, it's a relative height and weight ratio, your height to your weight. A BMI of 40 or less is associated with the best outcomes. So patients who have a BMI over 40 are at a higher risk for complications, including needing to stay in the hospital longer, blood clots, infections. All of these things go up if the weight gets excessively high. So if you want to know what your BMI is, you just go to Google and type in BMI calculator and put your height and your weight, and it'll tell you what your BMI is. Some people might need to lose a few pounds before they're good candidates for knee replacement. But BMI of 40 is a good place to start, and it's the best way to make sure that the complications are minimal and that there's almost no risk of having a bad outcome. Good question, Barb, and a very important one. All right, let's go to our next one. This is from Tim. Curious, how long is the rehab period? All right, so Tim, rehab starts the day of surgery. Like I said, your operation will be on a Thursday morning or a Monday morning, whatever day it is. You're up and walking that afternoon. So technically your rehab starts the same day as your operation. Once you go home, there's lots of options for ways that you can do physical therapy after a knee replacement. Those range from you can do exercises on an application on your phone, and we've got an app at the Rothman Institute that we utilize that you get texts and prompts and instructions on how to do exercises on your own. That's one end of the extreme, and it ranges all the way to a nurse can come to your house, a physical therapist can come to your house, all the way to you can go to physical therapy at an outpatient facility on your own. But all told, that physical therapy typically lasts about 6 weeks. Some people are a little faster than that, and some people will require a little bit more than that. But in general, most people will take about 6 weeks of physical therapy before we would consider them fully rehabbed and ready to go back to work. Great question. All right, next question is from Dom. Hi, how long does a knee replacement last? I'm 52 and years of sports have taken a toll on my knees. Am I too young to get a knee replacement? Well, Dom, just like our latest, the question where the person was 83, age isn't really the best determinant. But I'll tell you some important improvements that have happened in knee replacement that have changed this answer from just a few years ago. One of the things that's new about knee replacement is the plastic that we use. As you know, knee replacement, and I brought an example, I brought a model here. I don't know if you can see that. This is an example of a knee replacement that we would use. It's basically made up of 3 parts. A metal component on the femur, and then a metal component on the tibia, and then you can see there's this plastic liner that goes between the 2 pieces of metal. And a knee replacement, the plastic liner is sort of analogous to the cartilage. It's what the metal rubs against so that there's no friction and there's no pain. This is the part that was always sort of the weak link, the part that would wear out, the plastic. Years ago, that would last about 15 years was what we would tell people, and we were pretty close. There were some studies that showed 20 or 22 years, but about 15 to 20 years is how long a typical knee replacement would last. We've developed some newer plastics. In fact, the manufacturers of knee replacements have come up with a new way of processing the plastic called cross-linking that makes it so the plastic lasts much longer. So now we have highly cross-linked plastic. The problem is we haven't had it for very long, so I can't give you a definitive answer. But I can tell you that laboratory studies where they put knees in simulators and they use them and wear them out are showing that knees are lasting much closer to 30 years. In fact, there are some implants that have been approved to say that they will last for 30 years. Of course, individual results may vary and yours may not be exactly the same, but I think that 30 years is a good starting point, and I think it's likely that even at 52, your knee will last for a very long time. But it brings me to another point and another question, because some people will say, well, I've been told I was too young for knee replacements. My knees are bone on bone and I've got terrible pain. I'm waiting until I'm old enough to get them replaced. And sometimes I'm not sure that that's always the right approach. I always think of it this way. If your knee is going to last 25 years and you're in your mid-50s, if you wait 5 years, basically you're buying 5 years in your 80s that your knee will last longer. So you're suffering in your 50s so that your knee will last through your 80s, and sometimes I think that's not a very good trade. I think a better If your knees are bad and you've got severe arthritis and a knee replacement, as judged by your physician and your x-rays, could help you, it might be a good idea to consider it earlier than later so that you can get on with your life. Because honestly, in your 50s, you're still working, you've got grandkids or baseball games or walking the boardwalk, whatever it is you like to do those things in your 50s. And then we'll hope your knee will last through your 80s and into your 90s. But if it doesn't, we'll figure out something to fix it. Great question, though. All right, let's go on to the next question. This is from Jack. I was told I need 2 total knee replacements. Do you recommend doing them at the same time? What are the advantages or disadvantages of doing them at the same time? All right, Jack, so this kind of goes back to the question a little bit earlier that we had about bilateral knee replacement. Doing them at the same time is called bilateral. There are certain advantages, but first of all, just as a reiteration, you've got to be almost perfectly healthy to be a good candidate for bilateral knee replacement. If you do meet that criteria, if you're healthy enough to have them both done at the same time. The advantages of doing them both at the same time is that your total recovery period is shorter. You're up and moving and walking and recovering quickly, and then you don't have to come back and get the next one done. The disadvantages are that the risks are slightly higher. The risk of major complications is higher if you do both knees at the same time. That said, the risk of major complications after knee replacement is very small. So a small number times 2 is still a very small number. But it's a discussion that you should have with your orthopedic surgeon. I know I tell my patients, if they ask me my personal opinion, I typically recommend 1 knee at a time. But I have done them both at the same time. We do them both at the same time. But if they want my personal opinion, what would I do? I typically prefer 1 at a time. I just feel like I want to be as safe as possible. So, great question, Jack. All right, next question. I've been debating getting my knee replaced. Will I need general anesthesia? I'm concerned about that, and that's a factor in not moving forward. This is a question from Mitch. All right, Mitch, good question. There are 2 general ways of doing knee replacement in terms of anesthesia. You made reference to the first, general anesthesia. General anesthesia means that the anesthesiologist puts you completely to sleep, and they'll put what's called an ET tube or an endotracheal tube in your throat, and they will use a machine to breathe for you during surgery. That's traditional anesthesia, where you're totally and completely asleep. The second way, and which I think is probably the more modern way, is a spinal. You probably heard of a spinal. It's similar to an epidural when women have children. A spinal is a shot that they give you at the bottom of your spine right at the beginning of surgery. You'll lose all feeling from the waist down. You won't be able to feel anything. That way, you can technically be awake during the surgery. There are several advantages to doing it under a spinal. The first is that you're awake. You don't have a machine breathing for you, so you don't have to worry about developing complications from the machine breathing for you. The second is that the spinal lasts for several hours. So even after the operation is over, when you're awake and you're in the recovery room, you'll have no pain. That's a big advantage. So you can start your recovery soon. You can get up and get moving without that serious wall of pain. When you have general anesthesia, as soon as the anesthesiologist wakes you up, you get all the pain from the knee replacement all at once. So my personal preference is for a spinal. In fact, we push almost everybody to strongly consider getting a spinal. We just find that the risks are lower, that the pain is better managed with the spinal, and the patients do better with the spinal. So that's a conversation you should have with your orthopedic surgeon, because I think that most people consider now spinal is sort of the gold standard. It's the way to do knee replacement. There are still some people who believe in general anesthesia, but I think that the literature strongly is moving towards supporting spinal over a general anesthetic. Great question. All right, next question. What is the rehab process like, and how soon can I resume playing sports, like baseball? This is from Kenneth Geiger. All right, Ken. Baseball. So you can resume playing sports somewhere between 6 and 8 weeks after surgery. It sort of depends on what you're talking about by sports. If you're talking about golf, absolutely, by 6 weeks you should be swinging a club. If you're talking about baseball, well, it depends on where you play. If you're the pitcher, you might be able to play sooner than 6 weeks. If you're an outfielder and you got to track down a fly ball, you might want to wait until somewhere between that 6 and 8 weeks. The truth is, though, that we don't have a firm number. There's not an absolute, well, you can't do this until a certain time. Your wound and the muscles and tissues around your knee will be healed right around 2 to 3 weeks after surgery. How quickly they get strong again and how quickly you're able to use them forcefully again is sort of up to you and your therapist and how hard you're able to push for rehab and start getting back to using them as quickly as possible. So the rehab process, I think and I hope that my patients would say, it's fairly aggressive. We want to get you up and we want to get you moving quickly. The faster we can move you, the better. And that's a change. When we're talking about the improvements to knee replacement, that's a change from, like I say, not even that long ago, 10 years ago. When I started doing this 10 years ago, we didn't even get patients out of bed until day 2. They literally sat in bed for 2 days because we were afraid that if we moved them too soon, that something bad would happen. Now we know that that was exactly the opposite of what we should have been doing. That when you're sitting around waiting for something bad to happen, something bad could happen. So now we get you up and we get you moving right away so that those complications like blood clots, pneumonia, all the things we're trying to avoid, those are minimized by getting you up and moving you quickly. And then rehab is the same way. The faster you can move your knee and the quicker you can get back to doing things, the faster you'll be back to your life. Good question. All right, let's go to our next question. This is from JW. What techniques can be done to prolong the need for a joint replacement? Okay. Great question, JW. This comes down to, let's talk about knee replacement. Knee replacement is for what we call end-stage arthritis, when your knees are completely worn out. Earlier, somebody mentioned bone-on-bone arthritis, when there's no cartilage left. Before you get to that point, there are some things you can do to sort of get as much mileage or to get as many years out of the knees you've got before you need to have them replaced. The first is stay active. It's counterintuitive. You might think that if I use my knees too much, I'm going to wear them out faster. In fact, that's not entirely true. Studies show that patients who walk and remain active are more likely to have better function and less pain from their knees than patients who sit around and wait for them to hurt. Sitting around waiting for them to hurt is likely to result in them hurting. So, keep moving, keep walking. Now, that said, if you do have some early arthritis, maybe you've already seen a doctor and you've had injections in your knee, or maybe you've taken some ibuprofen or some medicines for your knee, there are a few activities that would probably be a good idea to alter in your life. Specifically, if you've got arthritis in your knees, but you haven't had your knee replaced yet, it might be a good idea to stop running. Running, and we talked about earlier, if your knees are healthy, running is okay. But if you've got some wear and tear and some loss of cartilage in your knees already, running may not be the best activity. Now that said, walking is great activity. Bicycling is a great activity. Swimming is fantastic. The elliptical at the gym, the treadmill, these are great activities. I always tell my patients, low impact, high cardiovascular output. Get your heartbeat going, but don't be pounding on your knees. Pounding is bad. But walking and smooth, fluid motion is good for your knees, and it'll make them last as long as possible before you need knee replacement. All right, let's go to the next question. This is from Becky. Dr. Hozak did a double knee replacement on me at age 55, 13 years ago. What type of procedure would I need in the future when and if the pain returns? All right, Dr. Hozak is one of my partners at the Rothman Institute. In fact, I trained with Dr. Hozak a few years ago. He's a good friend and a mentor, and he's a fantastic surgeon, Becky. So 13 years ago, you had your knees replaced. Well, if your knees start to give you more trouble, there are two possibilities. I'm going to go to the model again. This is the model of the knee replacement we had. What we hope is that the metal components have maintained their good position and they're still firmly attached to your bone. If they are, then there's the possibility that the plastic has worn out. And that it is possible to go in, let's see if I can get this one out, and we can change the plastic. I can't get it out, but this plastic comes out. You can take the plastic out and put in a new plastic. So if you start to have trouble with your knees, and the best thing to do is see your doctor. You can call Dr. Hozak and get an appointment, and go in and see. An x-ray will determine what's wrong. If the plastic can be replaced, and that's what we hope for, then it's a very simple operation to go in, remove the old plastic, kind of clean out the debris in the knee, and put in a new plastic. And then 13 more years is what we hope. So hopefully, Becky, your knees will last longer than 13 years. I hope they're still working and still going good. But if you do have problems, that's the thing you should do, because it usually can be fixed simply. All right, let's go back to the questions. When can I return to work after surgery? This is a question from Karen. Karen, good question. It depends on what kind of work you do. Let me give you a range because I don't know what you do. I think if you've got a sedentary job, if you sit at a desk, if you do some typing, you're making phone calls, it is not unreasonable to expect to be able to return to work somewhere between 2 and 4 weeks after surgery. Now, that said, you still need to do your physical therapy. So if you're going back to work, you still need to be able to do your exercises, either at home with the application from our office or with the physical therapist. Somehow you got to keep up with your physical therapy. So if you can do that and still go to work, then 2 to 4 weeks, I think, is reasonable. Now, if you've got a more labor-intensive job, let's say you carry bricks up a ladder at a construction site, 6 weeks is probably more of a realistic expectation. Now, remember, we're not going to put the brakes on you. We're not going to tell you don't go back and do these things. I think that you'll find that you probably won't be ready to go back to carrying bricks up a ladder until about 6 weeks after surgery. That's a good average. If you're on your feet frequently, 6 weeks is a good number. So, good question, Karen. Thank you. All right. This is from Greg. Will my implant set off metal detectors at airports and courthouses? If we're talking about knee replacement, yes. So you can go back to the model, and if you were here, Greg, you could pick this up and see. It's got a little bit of heft to it. The metal on a knee replacement is made out of what's called cobalt chrome and titanium. This will set off a metal detector. Now, in the past, we used to give patients little cards. You may have seen these that said you'd had your knee replaced, and then when you went to the airport, you gave it to security, and they let you pass even though you set off the alarm. Well, since 9/11, things at the airport have changed. They no longer really care if you have a card. If you set off the alarm, you have to be scanned, and TSA no longer accepts those cards. So we generally don't provide them for patients anymore. But you will most likely set off the alarm, but you'll be in good company. There's millions of people in the United States who have knee and hip replacements, and they set the alarm off. And I think that the folks who work at TSA are very used to it. And after a few flights, you'll find it's not really that big a deal. They just scan the wand over your knee, and when it goes off, they know that you indeed do have a knee replacement. Now, courthouses, the metal detectors, same thing. You will probably set it off, but a quick examination, and they'll figure out that you've got a knee replacement. Good question, Greg. All right, this is from Delilah. I understand you may need blood thinners to avoid blood clots. Is that accurate? Okay, so this brings up a good question because I think it hits on one of the improvements of knee replacement. And what we're supposed to be talking about today is that what things have changed and why is knee replacement better now than it used to be. Blood clots is an important improvement, I think. One of the risks associated with knee replacement was the development of a blood clot. Now, we never knew who was at risk of developing blood clots. So in the past, we used to give everyone blood thinners. Coumadin was what we typically used. Some of you may be familiar with Coumadin. It's a drug that's designed to make your blood thin so that it doesn't clot. But it has some side effects and it has some problems with it. Specifically, you have to have your blood tested 2 to 3 times a week to make sure it doesn't get too thin. You have to watch your diet. You can't drink red wine. You can't eat green, leafy vegetables. All these things made Coumadin sort of less than ideal. Recently, though, there have been some new studies that showed that there are some alternative medicines that might work better without all the side effects and all the problems associated with Coumadin. So a few years ago, we started using aspirin. Yes, plain, regular aspirin. Now, what's important to understand, though, is in addition to the aspirin, we've also made improvements in the way you recover. You remember, we used to have you just sit in bed for 2 days before we even got you up. It turns out that the risk most likely to lead to a blood clot is what we call stasis, not moving. So, one of the things we're going to want to do is get you up and moving quickly. And if we do that, then instead of Coumadin, which is this very powerful blood thinner, we can use just regular aspirin. In fact, typically our protocol is an 81 milligram aspirin, so a baby aspirin, twice a day, once in the morning, once at night, for 4 weeks after surgery. And that's it. But the caveat is we also want you to be up and moving. We don't want you sitting around. because getting up and getting moving is going to be the most important thing that prevents you or helps you avoid developing a blood clot. Great question, because the improvement is that with aspirin, we no longer see the swelling that we used to see with Coumadin. We don't see the drainage after surgery that we used to see. Less drainage, less swelling also means less pain, so a faster recovery. This is a significant improvement, and it's ironic that it's a medicine that we've had for over 100 years, but simple aspirin is what we're using now to prevent blood clots. And having done that now for a few years, we're finding that the risk of blood clot is no greater, and in fact I think there are some studies that would say it's even less than it was when we were using the much more aggressive blood thinner, Coumadin. Great question, Delilah. Thanks for your question. All right, this is from Ed Gibbs. It's been a while since I met with a doctor about getting the knee replacement. I think I'm ready to get it done. How do I make arrangements for surgery? Ed, great question. A lot of people are probably in this situation. I meet with patients sometimes, and the first time they hear me say knee replacement, they get this look on their face like, you're kidding me, right? But ultimately, it sinks in because the knee continues to hurt, it continues to be sore, and eventually, you just need to get the knee replaced. The first place to start is by meeting with an orthopedic surgeon. We have several orthopedic surgeons who specialize in knee replacement at the Rothman Institute. If you go to the rothmaninstitute.com, our website, you can see a list of all the surgeons who specialize in hip and knee replacement. There is almost certainly one close to where you live. We have 17 offices, I believe, now. And all of those are going to be somewhere close to where you live. And a meeting with your physician will help set the process in motion. He'll take some x-rays, he'll examine your knee, and together you'll come to a determination if the time is right. But it sounds like you've been dealing with this for a while, Ed, so it might be the right time. Great question. Good luck. I think you're going to do well. All right, this is from Helen. Is there any chance of failure, implant failure? What would cause a replacement, a knee replacement, to fail? Can your body reject it? Good question. This is one I get a lot. There are a couple of things that would cause a knee replacement to fail. Thankfully, they're very rare and unlikely to happen. But since you asked, let's talk about them. The first is infection. This is one that we're always very, very careful to avoid during surgery. In fact, when you go for a knee replacement, you'll see the process to help avoid infection is extensive. You get soap to help you wash with for a week leading up to surgery, special wipes the morning of surgery, a special preparation during surgery, and then a special dressing after surgery. All these things to prevent developing an infection. In spite of our best efforts, though, there's still a very, very small chance that infection could develop. If it does, we'll take care of it and we'll fix it and get it taken care of. But that's one of the things that could be a problem is infection. Again, it's a very, very low risk. But it's not zero. We're working towards it being zero, but we're not quite there yet. So another cause of failure is what we call loosening. A traditional knee replacement is cemented in place. So these metal parts are attached to your bone using bone cement. And that holds and lasts for a very long time. In fact, 30 years, I think, is a very good possibility. And I've seen knee replacements that have been in for 30 years. But there is the possibility, thankfully very rare, that the knee replacements could wiggle loose, that for whatever reason they become detached from the bone. If that does happen, we'll find a way to fix it. Typically it requires what's called a revision surgery, where we go in and we remove the old implants and we replace them with new ones. But on occasion that does happen. As far as your body rejecting it, that's something we just don't see. Patients a lot of times will ask me about metal and they've got metal allergies. But if you study people who have knee replacement, their likelihood of having a metal allergy to their implant is very low. Very, very low, like 1 in 50,000 low. It's so low that it's not something that we spend a lot of time worrying about. We're more concerned with getting you up and getting you moving quickly. But if you do have an allergy to metal or you've had some issues with metal in the past, it's a discussion that's probably worth having with your orthopedic surgeon prior to the time of knee replacement. He can share with you some of the new literature and you can talk about it. But the incidence of patients rejecting their knee replacement is very low. In fact, I'm not sure I can even say I've ever seen it. Maybe one patient in my entire career. It's very low and unlikely. Good question though, Helen. All right, let's go to the next question from Nancy. I was going to wait until after the holidays to get my knee replaced. If I move it up to the next few weeks, will I be up and around for the holidays? Probably. I would hope so. I always tell patients, everybody wants to know, how soon is my knee fully recovered? And that's a good question, but I think a better question is, how soon is my new knee, the knee replacement, better than the knee that I've got now, which is painful, which hurts at night, which hurts when I walk? And sometimes the answer to that question is the new replacement can be better than the one you've got very quickly. In fact, within a few weeks. Now, I will warn you, Nancy, typically when we schedule knee replacement, we schedule a few weeks in advance. There's a process, so when you go in and you make the decision that you and your doctor are going to move forward and you're going to get your knee replaced, we do need to get what's called medical clearance, where we send you to your doctor and they check on blood pressure and if you've got diabetes and if your heart is working well. All these things require medical clearance and evaluation, and sometimes that takes a few weeks before you can undergo the knee replacement. So if you're thinking about getting it done before the holidays, you might want to get on that and make a call to your surgeon and see if he's got some availability to get that done quicker, because it usually takes a few weeks of lead time to make sure that you're ready. But I would tell you, I want my patients up and walking and using their knees almost as quickly as they can. So within 2 weeks, I think you should be up eating family dinner. You should go on a family walk after dinner on Thanksgiving. You should take the dog for a walk on Christmas Eve. You should get up and use your knee quickly. And if you get it within a few weeks of the holidays, I think you'll find that you're going to be up and ready and back to life quicker than you think. All right, from Charlotte here. Will I notice anything different about my knee? Will the physical appearance change, be larger than my non-repaired knee? Well, good question. I'm going to go back to the model. There will be a scar on your knee, Charlotte. Luckily, it's not as big a scar as we used to use, but there's still no way to get these things in without an incision. So you will have a scar. But I think you'll find that after time it heals and is not noticeable. The swelling in your knee should go down to normal. Now that does take some time. In fact, some patients will say that they have some swelling up to 6 months, some even a little longer than that after surgery. But eventually the knee will be about the same size as the other knee. And the only really distinguishing feature is that scar, which will be there forever. But most people, I find, after 6 months or so, the scar becomes just a thin white line and is not noticeable. So I would tell you the physical appearance is just that incision is the main thing. The swelling should go back to normal, and if you're wearing pants, most people won't be able to tell you've ever had a knee replacement. All right, good question. All right, let's go on here. This comment is from Maureen. I live alone, so I will need someone to move in with me. So will I need someone to move in with me after surgery to help me get around? Well, I don't know. I have lots of patients that also live alone, and it depends on what kind of a support system you've got. If your daughter lives next door, you may not need anybody to move in with you. Or if you've got a relative who's close and can check on you frequently, you might be able to get by. But if you do have somebody who's able to come and spend some time with you, it's not a bad idea to have some extra help. Now remember, you're going to be getting up, you're going to be moving, and I think getting out of bed and going to the refrigerator to make something for breakfast is good rehab. And in fact, I want my patients to do that. I want you to get up. I want you to get up and go do something. I'd rather not have somebody waiting on you and doing everything for you. But for peace of mind, it can be helpful to just know that somebody's there. So, Maureen, if you've got somebody who's willing to come and visit and spend a few days with you after surgery, I would invite them. I think that's a great way to recover from knee replacement. Good question. All right, next question. This is from JW. Do you foresee robotics as the future, or should our focus be directed more towards early interventions such as HA, which is hyaluronic acid, injections, cortisone shots, subchondroplasty procedures, etc.? Well, JW, that is an interesting question. Robotics is the future. I can't say for sure one way or the other. I will say this. 10 years ago, when I was finishing up my training, they said within 10 years, robots will be doing knee replacement. And well, now here we are 10 years later, and we're still not really fully using robotics for knee replacement. There are some technologies that I think can improve the accuracy of knee replacement, but they're controversial, and we're finding that the cost may not be justified because the outcomes aren't necessarily better with the use of robotics. That said, who knows? 10 years ago, I didn't think I'd have an iPhone that could tell me how to get wherever I need to go. So the future is hard to predict, but most certainly things will improve. Like I said, 5 years ago, knee replacement was drastically different than it is now. But it wasn't robotics or anything technological that made it better as much as it was small incremental improvements in lots of little things that made it better. So as far as injections work, but they tend to be limited. I would tell you that most people will have injections, but I don't know that they last for long periods of time. If you're in your 50s, you probably still need your knees for 30 or 35 years. Injections just aren't going to last that long, and eventually you're probably going to need to think about a knee replacement. But if the injections are working for you, especially the hyaluronic acid, the gel injections, cortisone injections can sometimes be harmful if you have too many. But if the gel injections are working, I would continue doing that. When the knee is no longer functioning with those things, that's the right time to think about a knee replacement. All right, this is from Mary. At what age do you get a knee replacement? Well, Mary, it depends on when you need it. I will tell you my youngest patient is 31 and my oldest patient is 94. So that's a pretty good spread in terms of how old patients are when they come in and it's time for a knee replacement. It's an individual discussion because sometimes I see patients whose x-rays look terrible. I don't know if you read my bio, I used to work in Montana, and we used to have what we called the Montana rancher who'd come in with legs that were so bowed from arthritis that he could barely stand up straight. And he would say, doc, they don't really hurt me that much, but I can't get around very well. And you look at these x-rays and they're terrible, and I don't know how people live with such pain. On the flip side, I've seen patients who come in with what look like perfect x-rays that don't show any signs of arthritis, and they say their knee is terrible and they can't live with it. So everybody's different, and everybody's response to pain is different. I would tell you the right time for knee replacement is when you can't get around anymore and do the things you enjoy doing. There might be something you really enjoy. Either it's walking the dog or taking your grandkids to the beach or walking the boardwalk with your husband, whatever it is that you enjoy doing. When your knee pain starts getting in the way of that, when the knee starts preventing you from doing the things that really make life worth living, I think that's probably the right time to start thinking about it, because it doesn't have to be that way. After the knee's replaced, you can get back to doing those things. You can get back to walking and enjoying the life that you want to live. So, good luck, Mary. Good question. Let's move on here. Drink. There's a comment from Marcia. Do you still use staples or glue like hip replacement? Well, this is sort of a moving target, and some surgeons have used glue and some surgeons still use staples. There are some advantages to glue. There are also potentially some disadvantages to glue. So the answer is both. Some people still use staples, some people use glue. The advantages to staples are that the staples don't close the knee up quite as tightly as the glue, so it allows some fluid to come out, and there's some thought that that maybe helps decrease the amount of swelling because the knee is allowed to sort of alleviate some of that drainage. The advantage of glue is that potentially it can lead to a better scar, but I don't think that's ever been proven. It's a discussion to have with your surgeon, because of all the things that go into a knee replacement, from the surgery, the recovery, the incision is probably one of the least important in terms of its effect on your overall happiness with your knee replacement. The incision will fade and become not so important, but the knee replacement on the inside, if it's working well, that's what leads to a good outcome. So I don't know that I'd get too hung up on staples or glue. It's a discussion to have with your surgeon, and whatever he feels works best in his hands or her hands is probably what I would go with. All right, next question. This is from Sonia. Is there any chance of avoiding surgery? Well, Sonia, that's a little tough to answer because we don't really know what your knee looks like. If you had some x-rays and could sit down with your surgeon, he could probably give you a better direction. If you've got bone-on-bone arthritis and you're in your 50s and you still need your knee for a very, very long time, then I think avoiding surgery is unlikely if you want to get back to using your knee. On the flip side of that, maybe you've only got minor arthritis and an injection may help you get back to doing everything that you want to do. It will depend on your x-ray and on the examination and what the surgeon thinks when he looks at you and your x-ray together. Either way, they can find something to make your knee work again, but those things play an important part in determining what needs to be done. All right, this is from Alan. I see the ads, but where is the Rothman Institute? Well, Alan, good question. I don't know that I can answer that. The Rothman Institute, our first office is in Center City, Philadelphia. It's across the street from Jefferson University. Since then, we have expanded quite a bit, actually. We have offices all over Pennsylvania and New Jersey. We just opened a new office in Marlton. There's one down at the shore in Egg Harbor. We've got one as far as Manahawkin and Cape May on the New Jersey side. There's one in Ballackinwood, King of Prussia. The best way to answer that question is to direct you to rothmaninstitute.com. There's a big tab that says location, and you pull it up with maps, and it'll show you all of the locations, including we've got a specialty hospital for joint replacement. We have urgent cares, offices. There are lots of options, but rothmaninstitute.com, and then click on the locations tab will probably give you your best picture of where the Rothman Institute is. I guarantee you, if you live in Philadelphia or close, there's one close to you. All right, this is from Glor. Will I need physical therapy, and if so, for how long? So this is kind of in keeping with the theme that we had a little earlier. Yes, Glor, you will need some form of physical therapy. But it depends on your surgeon and where you live and what your options are. Like I said, we've got an app that we're working with called Force Therapeutics, and if you've got an iPad or a phone, it gives you instructions and videos, and you can interact with the therapist, and we find that it works really well for patients. Now, some patients want to do more than that, and a physical therapist may be required to help you do that. But physical therapy is typically 6 weeks after surgery. Like I said a little earlier, some people are a little longer, some people are a little shorter than that, but I would tell you to plan on about 6 weeks of physical therapy after your knee replacement.
How about the difference between hips and knees? Can you describe it? I mean, they're very different rehabs.
Okay, so that's, yes, thank you, Rick. That's a question for Rick. We're talking about knees, but let's talk briefly about hips. The hip rehab and the knee rehab are different. Knee is a little more intense. I'm going to be honest, it takes a little more work to recover from a knee replacement. After a hip replacement, I tell my patients the best physical therapy is to walk. If you get up and go for a walk every day, you'll recover very quickly. You don't have to do all the formal exercises. Now, some people want to, and that's not a bad idea. But if you want to do as minimal rehab as possible, after a hip replacement, you just go for a walk every day. Knee replacement's a little more involved. It takes a little bit more work, a little bit more effort with your physical therapist or with the Force Therapeutics app to make sure you're getting the strength and the motion after surgery. All right, let's go to another one. This is from Paul. He says, I was talking to a neighbor who just had knee replacement about my replacement, and he mentioned the 6-week blues. How common is this? Well, lots of people call it different things, Paul. I don't know that I would call it blues as much as there's a lot of things that go into your knee replacement. Specifically, number one, you have surgery, and that's a big deal. And your body takes some time to heal. It takes extra energy and extra calories to recover from a surgery. So that's going to contribute to that. There's also a phenomenon where patients will complain of not being able to sleep well for the first few weeks after surgery. We're not sure what that comes from. I'm suspicious it may have something to do with the pain medicine, because in addition to the surgery, you're also getting these pain medicines. You're meeting with a physical therapy 3 times a week. You're doing all these things, and those things can contribute to sleep disturbance and the blues, or having a difficult time with maintaining a good attitude. I would tell you that the most important thing to avoiding that, again, is getting out and walking, get some fresh air, use that new knee, get some use out of it, because now that you've got it, you need to use it, and that, from my perspective, is the best way to avoid getting the blues. All right, next question. Can you get knee replacement if you weigh over 300 pounds? This is from Tony. Well, Tony, yes. As long as you're 7'5", then you can get knee replacement if you weigh over 300 pounds. We talked a little bit earlier about body mass index, which is a ratio of height to weight. In general, hip and knee replacement is restricted to patients who have a body mass index less than 40. It might be if you're on your computer, you may want to open up another tab, look up BMI calculator, and put in how tall you need to be at 300 pounds to get your BMI under 40. In general, knee replacement is what we call elective surgery, meaning it's for patients who it's not a life or death operation. And so we want to make sure that we do it in the best way possible and minimize the risk of complications. And one of the risks of complications is excessive weight. In fact, there are some studies that show that having a BMI over 40 results in a 17 times increased risk of complications after a joint replacement. That's a risk that's just probably not acceptable to you or to your surgeon. So, one of the things you should start with if you're in that situation of 300 pounds, and if you're not 7'5", would be to work on losing the weight. You may be surprised how much better your knees feel if they don't have to carry that extra weight around. All right, good question. Let's go to another one. I just had lateral hip surgery in July. Is it too soon to get the knee replaced? No. That's from Carol. Carol, good question. A lot of times, hips and knees go together. Specifically, I don't know which hip you had replaced and which knee hurts, but there are several studies that show that left hips and right knees tend to go bad together, because for all the years that the hip was hurting, you tend to shift weight to the right side, which puts an extra strain on the right knee. And so I have many patients who, after their left hip replacement, say, okay, the hip's great, now let's fix my knee. So typically, if you wanted to do surgery as quickly as possible after a joint replacement, it's about 6 weeks is about the fastest you can do it. So if you had your hip replaced in July, you should be ready to have your knee replaced anytime in the near future. It's a conversation to have with your orthopedic surgeon. I think he'll tell you that July to November is plenty of time to recover, and it might be nice to get it done in the same calendar year for work and other things like that. Good question. This is a question from Kev. Will I need to take pain medication after the replacement? Probably. Now, I think that that's changed. We're using a lot different medications than we used to. It used to be that we gave patients pretty powerful narcotics after they had their replacement, and those had their own side effects. And there are still some situations where narcotics might be appropriate. But what we're finding is with the right rehab and the right medicines during and then immediately after surgery, that we can minimize the amount of pain you're having after surgery. Now we use much more anti-inflammatories, and that decreases your need for narcotics. But in general, you probably will need some type of pain medication. Remember, the physical therapy, when we're talking about a knee replacement, physical therapy after knee replacement is designed to improve the motion of your knee, to get as much motion and as much strength as we possibly can. As it turns out, narcotics or pain medicine might be required to get as much motion as we possibly can. We want your therapist to really work with you to get it as strong and as flexible as possible. Right after surgery, that might be uncomfortable, and so the pain medicine helps you get through that. Good question. All right. Got time for a few more. When can I immerse my knee totally, such as for bathing or swimming in a pool? Well, so after knee replacement, you'll have an incision. The rule is, Claire, it's got to be completely and totally healed. I tell my patients that's about 3 to 4 weeks. It's absolutely not before 2 weeks, but somewhere between that 3 and 4 week time period is usually the right time. Now, you can shower. In fact, you can shower almost immediately after the knee replacement and let water run over the top of it. But before you go swimming in the ocean, you should give it a few weeks to make sure it's totally and completely sealed up. We don't want any ocean water inside of your brand new knee replacement. That's only going to cause problems. So give it 3 to 4 weeks typically. All right, this one is just from a guest. What do I need to do to prepare my home for recovery? Well, it depends on what your living situation is. Some patients have bedrooms which are on the second. I've even had a patient whose bedroom was on the 3rd floor. It might be a good idea to make sleeping arrangements on the main level. Try to minimize the amount of times you've got to go up and down the stairs. It also might be helpful to make sure that you've got simple meals that are easily prepared during the time that you're recovering from surgery. Make sure you know where the TV remote control is, but also make sure you know how to get outside and go for a walk. But the one thing I can tell you is make sure that your sleeping arrangements are easy to to get around. Get the clutter cleaned up. You don't want to have to trip. After surgery, you're going to have a cane, maybe a walker to get around with. You might look around your house and see that tight spot between the table and the chair, it's going to be difficult to get a walker through. You might make those kinds of cleanups or arrangements just to make the house easier to get around right after your surgery. All right, let's go to another one. This is from Peggy. How long will the knee replacement operation take? Well, Peggy, the actual operation takes your surgeon about an hour to do. Now, there's some setup time, and there's some time when you're waking up, and then there's some time in the recovery room. So the whole process is probably 3 hours or so, but the actual operation itself takes us about an hour. It's the recovery that's more important, though. There's a question from Sal. This might be tough to answer, but generally, when is the right time to undergo a knee replacement? I'm not sure I'm there at this point. Sal, let me tell you about one of my favorite patients. After I finished my training, I went home. I'm originally from Utah, and I went and practiced in Utah for a little while. And one of the nice things about practicing was where I grew up is that I got to see some of the people that I'd known growing up. And one of my favorite patients was a lady who actually worked at the elementary school where I went to school. I knew her knee was bad. I'd seen her hobbling around on it for years prior to coming and seeing me. When she finally did come and see me, sure enough, her x-rays showed severe arthritis. And we did her knee replacement, and she did great. And so I had to ask, I said, what was it that finally pushed you over the edge? I knew your knee was bad for years. What finally made you come and get it replaced? And she says, well, you know what it was, is that I love to garden. Gardening is my thing. And I have a little garden patch out behind the house, and I used to walk down the hill and garden. Well, after a while, my knee hurt so bad that I couldn't get down there. So my husband bought me a little four-wheeler. These things are common in Utah, a four-wheeler. And so I could drive down to the garden, and I could still garden. But eventually my knee started to hurt so much that I couldn't even get on the four-wheeler to go down and garden. And that was the last straw. I was not going to continue to live with this knee pain if it was going to interrupt the thing that I loved the most. So she got her knee replaced, and she was happy to tell me that she had just harvested her potatoes and green beans that year. She put her garden back in. So whatever it is, Sal, there's something in your life that's sort of the last straw. When you can't do those things, that's the time to start thinking about it. And it might be something not as complicated as gardening. It might be walking on the boardwalk for a mile. Whatever it is, when you reach that threshold, that's when you should at least visit with your orthopedic surgeon and see where you're at in the process. All right, this is from Umi. Will physical therapy be painful? There is some pain associated with physical therapy after knee replacement, but I think more importantly is to know that it's pain that can be managed. The pain medicines we use and the techniques we use make it so I think you'll be surprised at how much pain you don't have. I don't think anybody expects to have a completely painless experience after they've had a major surgery, but improvements in the last few years have made it so that the pain is very manageable. In fact, I think most patients would say they were surprised that it didn't hurt more. So the pain will be taken care of. You got time for one more? A couple more? This is from Claude S. Well, I feel depressed after total knee replacement. This kind of goes with the question about the blues earlier. I don't think we see that often. I think patients, for the most part, recognize that they're going through a period of time when they're recovering, but I don't think depression is really part of that. I think that patients, actually, it's sort of like beginning a new lease on life, and they feel challenged by the goal of getting their motion and getting back to doing the things they enjoy. So depression isn't something I seek frequently, and it's not something that I think would let me stand in the way of getting my life back and getting my knee replaced. So I don't think so, Claude.
Dr. Post, talk a little bit about some of the things that the Rothman Institute is studying, some of the studies that we're doing, some of the different things that we're looking at.
Excellent. Well, this one study that we've got going currently is some different medicines and their effect on sleep disturbance. Since we're talking about depression, we do see patients who have sleep disturbances after knee replacement, meaning they don't know exactly what it is. In fact, they're very quick to point out it's not the pain, but for whatever reason, they just can't sleep. So we've got a current study going where we're looking at a couple of different medications. One of them is melatonin. I don't know if any of you are familiar with melatonin. It's sort of an herbal medication that's supposed to help people sleep, compared to a different medication and a placebo. And we're looking at see if those things help people sleep better after surgery, because it's not the pain that's causing them to have trouble. It's this something that we just can't quite pin down. So that's one study that we've got going on right now. Another study we're looking at is different types of pain medicine and how those affect patients' requirement for narcotics. There are lots of medicines that are non-narcotic that we can give after surgery, and we're finding if we use the right combination of several different medicines in small doses that we can decrease the amount of narcotics which are required. And less narcotics leads to less depression, and less, all kinds of problems are avoided by avoiding narcotics. Those are just a couple of questions that we're trying to answer at the Rothman Institute through our research division. And it's one of the things that I really love about working at Rothman Institute is that not only do we get to do surgery and we get to help people get their lives back, but we also have research going on that we can figure out questions to problems that have been going around for years. We can solve some of the difficulties of knee replacement and make it better for future generations and even for right now. And that's an exciting part of my job. It's something that I really enjoy.
Okay, here's our last one.
Last question. All right. What is revision total knee replacement? This is from Marguerite. All right, Marguerite, we got just a couple of minutes, so let me tell you. A revision knee replacement is if you have had a knee replacement at one time in your life and you need to have surgery again for whatever reason. The plastic wore out, something broke, heaven forbid. If something were to go wrong with your knee replacement, a revision knee replacement is where we go in and we fix that. We revise the knee replacement you have and make it better. That's a revision knee replacement. I hope you don't need one, but if you do, we can take care of you. All right, I think that brings us to the end of our web chat. Thank you for all the questions. We had a very exhaustive list of a bunch of good things. I enjoyed being a part of it. And if you have any further questions, don't hesitate to contact us. The RothmanInstitute.com is our website, and we can be put in touch with any of the surgeons, including myself, and see you in person and hopefully help you get rid of some of the knee and hip pain. Anyway, thank you very much. Have a nice afternoon.